Assalamu alaikum, everyone. My name is Rana Kamran Mahmood. Today, we have with us Dr. Sidra Khan. Dr. Sidra Khan is currently a PhD scholar at UK in collaboration with NHS Hospital. She graduated from UK when did MBA in the healthcare management, MS in pharmacology, and then MSc in pharmacy practice from the University of Huddersfield, UK. She is registered member of various pharmacy societies, including FIP, ACCP, served as a task force committee member for ISOPP, Joint Secretary PPA-SIN. She was associated with the largest transplant center in Pakistan for about 14 years in the various positions and served as a manager pharmacy for the 10 years. Throughout her career, she worked in many specialties, including oncology, renal disease, transplant, as well as in infectious diseases, established pharmacy setup, including ambulatory care services, oncology, aseptic dispensing unit, PNA, extemporaneous preparation, inpatient pharmacy, pharmaceutical care management for transplant and oncology patient, and drug information services. Thank you very much, Dr. Sidra Khan, to be with us for infectious disease part 2. I will allow you to please start your presentation. Thank you very much.
Welcome everyone. So this is the continuation of the first part, the infectious diseases. So Kamran is already introducing myself. I'm Sidra Khan. Currently, I'm the PhD scholar at the University of Huddersfield, England. And I'm off to my clinical services nowadays, since last 2 years almost. So let's get started. Before starting my presentation, I would like to disclose something. There is no financial, or the funding or the relationship to be disclosed during this presentation. We are not going to be use any trade name or any promotion of any brand. There is no conflict of interest. And all the material was taken from the ACCP Pharmacotherapy Preparatory Review and the recertification course from the 2020 and 2021. So just started with because I have to rush, I have to do something really else. So sorry to say if I'm rushing aloud. So you already have this session before last year. So you may go through that for further details. So just started with the human immunodeficiency virus that is very commonly known as HIV or the AIDS. We all are very aware of it. So its transmission is basically occurred through the sexual transmission, parental exposure, like if somebody's infected, if you guys remember, I think a couple of years before in the Pakistan, especially in the Sindh, there was an outbreak of the HIV in the most because of this parental exposure, and prenatal transmission, which is very not common in our societies, but like in the sexual one, but related with the BCPS, you guys have to know about all the risks and the prevalence factors that is occurring in that Western world, because this test is basically recording according to their own, experiences and what they are going through it. So just focus on that. Maybe one of you or any of you have already been involved in the HIV services or whatever. So there's lots of drugs that's not available in the Pakistan, but it's available internationally. So when you're preparing for your exam, so just keep in your mind, although the evidence practice is very important, but related with this, you also have to check with all the international guidelines and what are their practices. It's very, very important. So yeah, pre-exposure prophylaxis. So everybody has to know about it, like using those who are at the substantial risk for acquiring HIV, including anyone in ongoing relationship with the HIV positive partner. Definitely they are prone or more, there's chances to get the infection. Use of the tenofovir fumarate is 300 mg plus tricycline 200 mg daily is usually recommended for the pre-exposure prophylaxis for these kind of patients, basically. And they have to be tested 5 days for the HIV antibodies. And if the prophylaxis discontinue, check renal functions is very important with all the patients who are taking tenofovir every 6 months. So universal precautions, if we are talking about the precautions and preventive measurements of different infectious diseases, it's very important that how to get the, how to just get avoided with this, because we all in the post-pandemic or in the pandemic. So we all know that we have to be taking lots of precautions and getting into it. So like related with HIV, which is a combination of the different diseases. So we should know that how to get preventive or get the precautions. So this is basically applied to all the blood, body fluids containing visible bloods, semen of the vaginal secretion, tissues, cerebral spinal fluid, synovial fluids, pleural fluids, peritoneal fluids, and pericardial fluid, amniotic fluids. Means exposure to any of these may anybody can get get exposes and get this pathogen. So these apply to all of these things, and some which are not applied, like the fecal, nasal secretions, sputum, so it's tears, urine, vomiting, and breast milk, or the saliva, they will not contain the HIV virus. So it's not we should not consider that secretions or these to be as a for the prophylaxis or to get the preventive measures. The diagnosis, in the case with the diagnosis with the HIV, is very important. There have you can see that is very important at how to diagnose. In the step one, the screening, definitely. There is a screening process, like you have to check the antigen and antibody tests, and it's readily available in the Pakistan also, both of the tests. And there is qualitative and quantitative, both the tests. It's very important because related, if we are thinking about or taking somebody on the treatment, so that's we know the viral load and everything. So in the first step, if the patient is negative, definitely the patient is not infected with HIV, but it is positive. We have to reconfirm that the patient is positive or not. So if it has become positive, then we started with the with the treatment. But if it's come negative, it's very important in that factor, because once it's become positive and next is the negative, so we have to be assured that the patient is positive or negative. That's why there's another test has been occurred that is known as a tiebreaker test to reveal that the patient is positive or negative. So this will be confirmation for that, these kind of a patient who have two sets, because usually we have a two positive test to confirm the HIV. So if one is positive and next one is the negative, then the third step has to be taken in this scenario. So diagnosis. So step one, I already told you the fourth generation HIV test, and there is a lots of testing available throughout the world. So in Pakistan, it's also available very commonly in the different healthcare settings, especially in all the tertiary care hospitals. And usually after post-exposure, it's take 18 to 29 days that the patient become infected. So if somebody is exposed and know that, so the onset may be 18 days usually, or more than 2 weeks. So HIV test that differentiate HIV 1 or from the HIV 2, because there are different variants. Variants are also available, we also see with the COVID that we have a lots of variants with the viruses. So viruses are very opportunistic, and they multiply and mutate it very easily. So we should differentiate a different kind of HIV. And so same happened with the HIV also. So HIV 1 is the nucleic acid amplification test, and it's very important to get it for the screening. And the test for the HIV RNA, which is known as viral load, which is very important if you are thinking about the therapies related with the HIV. So RNA less than 20 copies per ml to the 70 copies is the goal of the treatment. So when you have a viral load, so you should know that, what is the targeted viral load for that patient. So because a viral load means there's how much the virus is available in the bloodstream. So you should be considered as that. As a pharmacist, you should know that about starting with the treatment options. So it's important to use of the HIV RNA testing viral loads. So most important use of the viral load is to monitor the effectiveness of the therapy after the initiation of the ART. Definitely, if you have your, the quantity of that viral load, so you should know that's what is the load. And when you started with the treatment, after that, you should know, sorry, I have a sore throat also, so it will be, so it will take so you should have some baseline for that. So you should know that if the viral load, what was the viral load before starting the treatment and what will be after the treatment. So you have to make some benchmark. So diagnosis HIV infection for the baseline value to follow. Definitely the follow-up is very important for that. You must have the viral load with you. It's from 2 to 4 or no more than 8 weeks after the starting or the changing therapy should detect a significant decrease. So it's not like that, lots of the private sector, they start to keep doing the viral load. So you should know that as a pharmacist, you can intervene that when the therapy is started and when you can intervene, and when you have to go and check the viral load of that patient to check the effectiveness of the drug. That's very important. So every 3 to 4 months, while on the therapy, checking for increase, if it is on the increasing pattern, definitely is the therapy failure or the failure of the therapy. So it's very important. If you don't have a viral load, so you cannot be able to determine if the therapy is effective or not. So may consider the extension to every 6 months if the patient therapy is suppressed. Greater than the 2 years within the immune stability, and because that we know that the HIV is related with the immunosuppression and it's related with the immune diseases. So immune stability is very important in these patients. Whenever there is a clinical evidence or decrease in the CD4 counts, CD4 counts are very important related with any kind of immunocompromised diseases, especially like HIV, patient with the cancers, patients with the transplant, whatever. So these CD counts are basically very important because they are the type of the WBCs and play a very crucial role in the immunity. So you should know what are the CD counts. I'm not going to give you the very detail about the CD counts, how they know, but they usually can, you may heard about lots of time about if you are in the clinical practice about the T helper cells or T lymphocytes. So these are the CD counts, and it's very important for any management of the therapies with the patient with immunocompromised status. So measure of immune function is used to determine the timings of ART, like antiretroviral therapy, opportunistic infections, prophylaxis, disease progression, and survival. And the normal values are ranging from 500 to 1300 cubic millimeter. So, but the thing is that in some of these guidelines I checked that they have also at 500 to 1500 also. So you must recheck with the recent one, which is applicable for you, like in the CDC, it's I think 1500, if I'm not wrong. So changes greater than the 30% in the CD counts are considered clinically significant. If it's increased, definitely it means the patient is responding. CD counts decreases on average of 50 to 80 per year is untreated HIV infected virus. As I already told you about, the T cells or the CD counts are important related with the immune system. So definitely, if it is decreasing, it's meaning the patient has some immunocompromised diseases, and discussing about the HIV, so definitely it's untreated. The potent combination ART CD counts increase on average of 50 to 100 cells per cubic millimeter per year. So you have to be, when you are dealing with the patients with HIV, so you should consider all of these things. Monitor at the diagnosis baseline that after the ARTs started to guide discontinuation of the opportunistic infections, because the patients with the HIV, they must have to taking lots of the prophylaxis medicines. So every 12 months for those consistent on the therapy and with the CD count between 300 and 500 for at least 2 years, and it's optional also. So if the CD4 is greater than the 500, in those virological suppress for at least 2 years. So that's the virological means the viral loads is very important. So that's why we have to check about the viral load. The more frequent monitoring every 3 to 6 months may be needed based on the clinical symptoms and viral load testing. Okay, the primary HIV infections like phase is usually 6 months post-infection, like the patient has come up with a new. So characteristics is about the 40 to 60% develop symptom from the primary infection. It's abrupt onset, like 3 to 14 days. And for that, the immunization of the patient with the HIV is very important. Like as we know that HIV is related with the immune function, so no live virus vaccine has to be given because they are already become immunocompromised if you give the live viruses vaccine. They be harmful. I'm really sorry. Can you please put your microphone on mute?
It's done, doctor.
No, still I'm hearing something. Okay, thank you very much. So like different vaccines have to be given for these patients as a prophylaxis or the prevention of the secondary infections. So it's very important, like influenza vaccine is should be given annually, and it's not with the HIV. I think everybody has to be taking that, and in our country it's not, we don't consider that, but everybody has to be. And now I'm just giving the additional information because now we are in the pandemic or the post-pandemic. So we should know the importance of these vaccinations. And in our country, we are not very well aware of it. So influenza vaccine is very important, same as it is in pneumococcal vaccines. And there is a different variants in pneumococcal vaccines are available. That is PCP 13 and 23. So first, the patient with HIV, they have to give the 13 and 23. And in the Pakistan, it's also available. So, and the normal patient also have to take that one, just to be, because it's very prevalent then, in our country also. So we also have to take these vaccines. Like hepatitis B and A vaccine for all HIV patient or at the risk one. Meningococcal vaccines, A, C, W, these are the different kinds of the variants for all the patients with the HIV. So it's very important. Like, yeah, human papillovirus vaccine. It's also very important, especially related with the females in our society also, because it's also may prevent from the cervical cancers and different, but we are not, it's not readily available in the Pakistan, but related with the HIV infections, it's required a lot of, because HPV is not just for cervical cancers, and they also produce lots of other diseases in the males also. So it's very important with the patient with HIV because they have more chances for the opportunistic infections. So related with the HIV treatment, there are usually 4 kinds of drugs are available internationally or globally. These are known as RTIs, that is reverse transcriptase inhibitors. Another one is protease inhibitors, entry inhibitors, and integrates strand transferase inhibitors. And these are the 4 major class which are used to treat HIV patients. And very importantly related with the HIV, which is very comes into consideration related with the pregnancy. If the woman is pregnant, and because of that, because there's, I think you guys must heard about a lot of studies about the placebo, and there was a lots of ethical issues related with that. So you should know that if the woman is pregnant, so what kind of ART has to be given, and if it's not given, what will be the consequences? So because it's a transmissible disease, though, so we have to be thinking in mind, like the patient has to be treated. So pregnant women with the HIV receiving no ART, these are the different goals. Pregnant women with HIV receiving potent combination ARTs. ART, I'm again going to tell you that's antiretroviral therapies, and during the labor, and infant born to the mothers who are HIV positive. Pregnant women with the HIV receiving no HRT, initiate therapy as soon as possible, even in the first trimester. It's very important because it's a transmissible disease, and it's transmitted from mother to the fetus, so it should be initiated as early as possible. Preferred regimes included dual therapies, and nowadays dual therapies or the combination of therapies are very important. In the later, I will let you know why it's so different combination therapy like abacavir, lamivudine, tenofovir, and emtricitabine, lamivudine, and different type of the therapies are available in the different regions of the world. So it should be according to that. But as you guys are appearing for the exams, so just check on all these combination therapy that has been recommended by, like IDSA or CDC, or which is also because you guys have to be updated about all of these information from there, because it's basically American test. So all women should have the HIV antiretroviral resistant testing completed before starting therapy. Why we have to think about resistant testing? Because as we already know that the viruses are very, they're very clever, they're mutated. So that's why the resistant pattern, if there is any testing, we have to know that to check the efficacy of the therapy. So there should not be any, resistant with the therapy. So that's why the combination of the therapies are recommended. It should not be given only one drug. So that's why to, eliminate the risk of the resistant. So it's not with just for the case with the women, but it's recommended nowadays for all the patients with the HIV to check with the resistant test. So continue throughout the intrapartum period, means during whole the pregnancy, the ART should be continued. Pregnant women with the HIV receiving potent combination ART, continue current combination regimen, consider replacing alvelacrevir with the Combisi, start with the other letragrever, or I prefer protease inhibitors. So these are the different regimens which are using in the United States, so you have to know about it. The pregnant woman with the HIV in the labor nearly deliver. At that point, the intravenous zidovudine should be given. So this is the infant born to the mothers who are HIV positive. So these are the some drugs which can be given to these infants, like zidovudine 4 mg per kg per dose every 12 hours or twice daily for the 6 week, plus the nevirapine for 8 to 12 mg at the birth and 48 hours later, and the 96 hours after the second dose. Or sometimes the triple therapies with the ARV, like antiretrovirus therapy with the zidovudine, lamivudine, nevirapine is also given. And if the low risk of the transmission, there we should be carry on with the zidovudine for the 4 weeks only. Prevention of the post-exposure infection. You have to know about the post-exposure, so how to prevent. So begin with the 72 hours if it's a non-occupational exposure, or occupational exposure, begin treatment within an hour for the 4 weeks. These are the drugs which are, I just want to tell you about the little bit side effects of these drugs, which is also important related with your exam point of view. Nucleotide or nucleoside and a nucleotide RTIs. So these may cause the lactate associated with the hepatic steatosis. So it's very important with these drugs, if you see these side effects, so how to check the doses, how to change the doses, how to make alteration in the therapy. So as a pharmacist, you should know this. And very importantly, with abicavir, hypersensitivity reactions are very common with the patients with the HLA-B 5701. So what is this? This is basically a gene which testing has to be, or the screening has to be done before the initiation of the abicavir. So it's very important if you already check, because if the patient has genotype like HLA-B, this is the allele, the 5701. If it is positive, it means the patient may have a hypersensitive reaction with the abicavir, and this drug should not be given in those kind of patients. So related, so this has come in the precision medicine, and nowadays there's a lot of targeted therapy, precision medicine, or pharmacodynamics is very much involved. So now you have to be checked with all these drugs if there is any new update related with the pharmacogenomic or the sequences or SNPs or like that. So just go through it and check because they are going to be asked about these kind of questions very well. Tricetabine, that's very common rash, and hyperpigmentation is very commonly, and the lamivudine resistance developed quickly with the monotherapy. So that's why the lamivudine usually nowadays not used as a monotherapy or the single therapy. It's usually given in the combination of therapy. Zidovudine, it's most related with the bone marrow suppression, nail pigmentation, and very commonly myalgia is very, because I didn't see lots of patients in my practice with HIV, but with the zidovudine, yeah, I know that the patient is very few of them that they complain about the myalgia. It's very common. The drug interaction with the rifampin and the myelosuppressive agents is very common with the zidovudine. So if your patient is taking any other drugs like the TB medicine, any other myelosuppressive or these drugs, so you should check that there is a lot of drug interaction. Tenofovir, GI, renal, and the bone toxicities. So that's why the tenofovir is very important. So you haven't started with a tenofovir, you have to check about these patients like their GI symptoms. They should not have any hepatitis, or maybe it's undiagnosed hepatitis. So you have to check all the viral markers, renal check on, and the very important, the BMD, like bone mineral density test, has to be taken in consideration before started the tenofovir. There is two salt forms available of the tenofovir, and one is the alpha-metabolite, which is a prodrug basically, and is basically given to the patients with the hepatitis B patient, because with the compensated, they have a compensated liver, so they have a much more, as I already told it has a GI toxicities. So that's why it's they are given the prodrug, so it's not be causing lots of toxicity to these kind of patients. Nucleoside RTIS all metabolized by the CYP. CYP means cytochrome P450, and they have a 3A4. So all of these, they are inducer, and they have produce certain kinds of side effects. So you should be considered like if they have a rash, stuff, symptoms. So this is very common with these prescriptions, and GI hepatotoxicities. So just check it. And very importantly, the PPIs, proton pump inhibitors, are contraindicated with the H2 blockers like an antacid, because they have a very interactions, and they should not be given because they induce that, and they increase the levels of these drugs and have a much more side effects or adverse event has been observed. So like protease inhibitors, like there's a lot, not so much drugs in the protease inhibitor like Zanavir or lopinavir. I just see lopinavir and ritonavir, these four, the combination drugs, I think only once. So like these also eliminated by the CYP. And they inhibit the CYP3A4. So the toxicity is mainly related with the endocrine disturbance. So when the patient are on these drugs, so you have to check that their diabetes and their, like cholesterol levels, all of these things, it has to be checked before initiation of these therapy, like lipid profile, which we commonly known as lipid profile in our systems. So before starting these drugs, we have to check that because they may have some side effects related with these. They also have a drug interaction between atazanavir and the acid suppressive like PPIs. Usually all the ARTs, they have some interaction with the, acid suppressive or the PPIs and etc. or the H2 blockers. So just whenever you see the patients, so just recheck with the drug-drug interaction, either you have to stop the therapy or may change the doses. So entry inhibitors or the INSTIs. So again, the increase in the creatine kinase enzymes, which is also related with the certain toxicities and increase in the creatinine. So, and the bilirubin. So you have to be checked with all of these drugs, like what their side effects, how they come up with it. So it's very important to know it. Treatment of the patient who is on HIV positive. The optimal ART consists of the two NRTIs in the combination with an INSA. These are the NRTIs, which I already told you that the nucleoside reverse transcriptase inhibitors, and the INSTIs is the integrase strand transferase inhibitors drugs. So I already mentioned that the dual therapy is recommended. So you have to check with the creatinine clearance, and then when you have to give in with certain kind of a drugs, or when if the creatinine clearance is more than 70 ml per minute, so you can use the tenofovir disoproxil fumarate, but if the patient has less, clearance, so you should not be given that, and you should be given the other form, which I already told you about. That is the alphanamide, salt form, because it has a prodrug, so it may be have less side effect to these patients. So when you should check with the renal function with all of these patients when they are on tenofovir. To change therapy for the following reason, I already told you the practical reason: virological failure maybe also happened, and the virological rebound, like HIV RNA levels more than 200 copy after the initial suppression to the undetectable level. And sometimes immunological failure may also happen, like we can see that the CD counts are not decreasing, increasing, because so it is also there are two type of things you have to be considered. One is the virological load, and another is the immunological, failure, like in which you have to check the patient's CD4 counts. So two type of the testing for the quantification, like viral loads and the CD count. So virological failure, I already told you that in the virological failure, definitely the viral load is not decreasing or may have some resistance. So that's why prior to start of the therapy, the resistance should be checked. And there's a lots of precision medicine in which we check the different, patient genes or genotypes to recommend that which kind of a drug has to be given, or they may have some sort of resistance. So check adherence and consider reinitiation the same regimen, initiate a new regimen, intensify one therapy or boost one therapy based on the pharmacokinetic parameters. So that is, as a pharmacist, you should know about all the pharmacokinetics parameters, which is important related with all the therapies. So prior therapy with the resistance, start a new regimen. Definitely if it's resistance, you have to come up with a new regimen with at least 2 and preferably 3 fully active agents. So it's more than the dual therapy. Resistance testing, like genotypic, I already told you, like the test for the presence of the mutation known to cause the drug resistance. So genotypic is very important. Phenotype, like test for the inhibitory concentration needed to decrease HIV replication. So it's like it's also important. The genotypic and the phenotypic testing is very, very common for the treatment of HIV. An indication upon entrance into the care, virological failure during the potent, combination RTIS may also happen, all pregnant women with HIV. So these are the resistant testings that we can do that. Suboptimal suppression of the viral load, acute HIV infection before initiation of the therapy to determine whether a drug-resistant virus was transmitted. So related with this, HIV, there is one question like K is a 29 years old asymptomatic patient who is HIV positive. She's recently found out she's pregnant and is estimated to be early in her first trimester. Her most recent CD4 count was 170 cells per cubic millimeter, and her viral load was 100,000 copies per ml by RT-PCR, which is the best therapy for the K to prevent HIV transmission to her child. So any answer? I think they are not allowing answer to maybe. So the answer is D, like administer a potent combination antiretroviral therapy regimen. As I already told you earlier, like we have to be started, every woman, the pregnant woman, we have to be started with the therapy. So it's very important because it's a transmissible disease. So the woman, if it's in the early, trimester, the therapy has to be started to stop the transmission of HIV infections. So there's a rationale why the other is not, it's not correct and it's not the answer. So you may check later. I think they will going to be share all the slides with you guys. Now started with the opportunistic infections, like as we know that it's HIV is human immunosuppressive diseases, like the patient immune system is not responding well. So that's why the lots of the infections, they are prone to more infection. That's why it's known as opportunistic infection. Like when the immune system is not well and the surrounding, they may get lots of infection related with the different CD counts. If we see that there's a lot of, data and the research are available to show the relationship between the CD counts and the risk of HIV-related opportunistic infection. If the CD counts is decreasing, there's more chances of the different kind of infection. So that's why the mortality of these patients were too high because they have lots of opportunistic infection. They don't die with only HIV. Basically, they died because of lots of infection and they are not able to fight with all of these infections. So there's you can go through it and it's really interesting. Somebody is interested to know like how the CD counts and the relationship with these opportunistic infection. Few of them, as your exam point of view, I'm going to discuss with you. So first is the PCP, like we all know very commonly infection is very common in Pakistan also, like pneumocystic gibberish pneumonia or PCP or PGB. It's if the CD count is less than 200 cells. So it's you have to be checked that like when you have to start with the therapy, or you can give the prophylaxis for that. Sorry. The clinical presentation is like patients come up with a fever, shortness of breath, non-productive cough, and you may think about there is something going wrong with these patients, and they have elevated lactate dehydrogenase LDH test. Basically, diffuse pulmonary on the X-ray, you can see the diffuse pulmonary infiltrates and very important hypoxemia. So these are the major clinical signs and symptoms for these patients. And now I think nowadays everybody know about the pneumonia because of the COVID pneumonitis. So yeah, but you have to be differentiate between the viral and the bacterial pneumonitis. So they have a different typical pictures, and I just add a few things which is maybe not related with this right now, but as an infectious disease point of view, there's a procalcitonin test that has been used very widely to differentiate between the viral and the bacterial infection. If the ECT is not that much raised, which indicate the bacterial infection, that that patient should not be treated with the antibacterial. So you have to know as a pharmacist that what diagnosis test has been done to differentiate between the viral and the bacterial in case of pneumonia nowadays. So therapy is very commonly that we all aware of it, like if you guys are clinically involved in your settings, like trimethoprim and sulfamethoxazole, that is very commonly known as brand names. Is very commonly available in the Pakistan. It should be for 21 days, clindamycin, IV, or primaquine for 21 days, but pentamidine, trimethoprim, dapsone, atverkine. We usually use in my practice, what I experienced that like trimethoprim with sulfamethoxazole was a very good drug to treat that kind of in our society or in our population. Adjuvant therapy is also considered like corticosteroid, decreasing mortality. And when you guys go and rethink about the COVID, that's the corticosteroids are also recommended in that, like the dexamethasone, that the patient should take that. So it's already, we all that the patient with the ARDS, they must take the corticosteroids to decrease the mortality. So PCP prophylaxis, there must be the primary prophylaxis and then the secondary prophylaxis. I don't know, you guys know about the primary prophylaxis or secondary prophylaxis. And the primary prophylaxis that basically consider that we have to prevent anyone from the infections. And secondary prophylaxis is basically patients already have that disease or that patient have this infection. And then for the further, infections, we are just giving them a prophylactic or the preventive therapy. So it's very important related with the patients, with all the immunocompromised patients, either the HIV or having on the transplant or the oncological patients. So secondary prophylaxis, the patient after the PCP may be discontinued if the CT count is more than 200 and months for 3 months or longer because of the potent combination of ART. Primary prophylaxis, the patient with the CT count less than, definitely if the CT count is less, that means that the patient have still may chance to get infection. So if on the initial stage, if you see that the patient's CT count is very low, so you start with the primary prophylaxis of the trimethoprim with the sulfamethoxazole. Consider stopping when you have to the primary or the secondary prophylaxis is patient with the CT counts of 400 to 200. If the HIV plasma RNA level is below limits of the detection for at least 3 to 6 months. So the prophylaxis is very important. And because we already told that these patients are very prone to the infection, the Candida infections like fungal infections is also very common in this, and they become a fungemia, and it's very bad in these immunocompromised patients. The oropharyngeal Candida, which is very common, known as oral thrush also, and most of the patients, like more than 90% with the HIV positive, may have it. So it's usually we can see the creamy white or cut-like patches on the tongue, and we can treat it like 7 to 14 days with the fluconazole, and sometimes alternative regimen has been given, like itraconazole, posaconazole, or miroconazole, but fluconazole is really, really very good drug, and we literally use it with lots of patients, and it's very effective too. So esophageal candidiasis, again, the fluconazole is a drug of choice, either the oral or the IV or the itraconazole solution is basically given for these kind of patients. And alternatively, if it is not working, the voriconazole, caspofungin, mycophenolate, endolofungin, and the amphotericin B and lipid formulations of amphotericin B is also available. So these kind of when there is chronic kind of infection, to these drugs must be used. Valvular vaginal candidiasis, fluconazole 150 mg orally or for 1 dose, or topical azoles for 3 to 7 days, days may be used. On alternative itraconazole solution orally may also given. So no primary or secondary prophylaxis has been given in that case. Cryptococcus new form infection, it's also very prevalent in these immunocompromised patients, and because I deal with mostly with the transplant patients and the oncology patient, we gone through these patients like, and it's very when the patient you come up with these symptoms, and I do remember one patient, they have we don't able to detect which kind of infection, because on this MRI there is a lesion. And when we go through the patient's we take the history and patient history and family history and how he lives or whatever. So we come to know that the patient is having the pets at his home, like birds and pigeon. So then we go through the different testing. So we come up with that the patient has Cryptococcus infection. So while you are dealing with the patient, just take the patient history. It's very important if you are having an immunocompromised patient, because lots of surroundings is affected, affect their condition and may be very problematic. So the patient basically come with a low grade headaches, ultrasonicism, irritable, somnolence, like there is clumsiness, you can see very visible, impaired memory and judgment, behavioral changes. So, and sometimes seizures may occur lately, and the minimal, rigidity and the photophobia is also very commonly seen in these kind of patients. So diagnosis, basically, positive CSF cultures and their cryptococcal antigen test is very readily available in Pakistan also. So it's very, you can easily diagnose that patient. An elevated opening pressure greater than the 50 centimeter. This is not related with the pharmacy, but you should know about that. The serum cryptococcal antigen more than 1:8 ratio. It's you have to be for the diagnosis purpose. Like the patient have cryptococcal infections. The treatment is basically the induction therapy should be given with the liposomal amphotericin B with the flucytosine, and the amphotericin B plus flucytosine alternative therapy must also be given. There's a lots of drug and their doses. I'm not going to give you all the doses. You can check on yourself. So there are liposomal amphotericin, fluconazole, and sometimes on the maintenance therapy, fluconazole is also recommended. Delay initiation of the combination of ART in the patient with the cryptococcal meningitis for full 5 weeks because of the immune reconstitution inflammatory syndromes, IRIs. IRIs. It's very common with the patients if they are on the ARTs and taking these antifungals. So you should consider that. Conservative therapy may be also given for these kind of patients, like fluconazole and alternatively itraconazole is very common. Like MAC, like Mycobacterium avium complex, it's a bacterial disease. So if the CT count is 50, it's common in HIV patients. I never see this in my practices till now. So signs and symptoms is weight loss, intermittent fever, chills, night sweats, abdominal pain, diarrhea, chronic malabsorption, progressive weakness, anemia, and elevated alkaline phosphate. So in this, the therapy is basically macrolytic, azithromycin and clarithromycin is very commonly used in combination with the ethambutol for 1 year. And the other agent can also be considered as a preferred therapy if advanced immunosuppression is like CT count is less than 50. And you can also check the myobacterial loads in bacterial load or in the absence of the effective ARTs like rifabutin and the fluoroquinolones and aminoglycosides may also be used in the combination. Primary prophylaxis in the patient with the CT counts less than 50 may given like azithromycin or clarithromycin or rifabutin is very commonly used. So prophylaxis discontinue after the 12 months with the chronic maintenance therapy or the secondary prophylaxis. If the CT count is more than 100 for the 6 months or longer because of the potent combination of the ART and if the patient is asymptomatic, so you can be discontinued with the prophylaxis for the MAC and restarted if the CT count is below 100. And primary prophylaxis, like CT, we already checked the CT counts at the 50. It's a very alarming, CT count. So the patient have to check with the lots of the, give lots of the primary prophylaxis. So who are not receiving ART or who have the viremia on current ARTs, maybe discontinue if the CT counts is more than 100 for 3 months or longer. Do remember the one thing that the CT count has to be maintained for the longer period of time. If it's fluctuating, this means there is not effective regimen and the patient may get the opportunistic infection. So that's why every time the CT counts for the 3 months or the longer, it's recommended. So primary prophylaxis is not recommended. The patient are immediately initiated in ART. Clarithromycin, azithromycin, either with the once weekly doses or the twice weekly. There is a different dosage regimens available for the azithromycin, and alternatively, rifampicin is also used, but it should be taken with the food because they have a lot of GI adverse effect. Yeah, cytomegalovirus. I have seen a lot of patients with the CMV, with either with the rhinitis, esophagitis, pneumonitis, and neurological symptoms. Not that much, but yeah, it's. But luckily, in Pakistan, we also have all the drugs regimens are available. So the treatment for the CMV, rhinitis, or the esophagitis, and everyone is like, well, ganciclovir is the drug of the choice, like 900 mg twice daily for 3 weeks usually, and followed by the 300 and 900 mg orally. And alternatively, if well, ganciclovir, because it's quite expensive, so in lots of the setting they use ganciclovir, but foscarnet and the cidofovir, but in the Western world, they use ganciclovir and foscarnet, and the cidofovir when the patient is not able to take orally. But in our society, like, because it's very expensive, well, ganciclovir, so that's why the patient may get ganciclovir, and we also use at the UPAT. So patient come as outpatient and take the therapy. So it's like that. If the site threatening lesion, if the patient have the, it's a very worse kind of a lesion, the intravenous injection of the ganciclovir or foscarnet may be used for 1 to 5 days, and other CMV infections. So esophagitis or colitis, we have seen a lot of patients with esophagitis and colitis, and the ganciclovir followed by the ganciclovir. We also adopted the same regimen. And alternative therapy foscarnet, ganciclovir also be used if tolerated. Pneumonitis, use ganciclovir or the foscarnet at the rhinitis doses. They have the same doses. And neurological, if they have, the patient is come with the CMV neurological, so combination of the ganciclovir and the foscarnet at the rhinitis doses that we already discussed previously. So secondary prophylaxis is necessary for all patients. So see individual drugs for the specific doses, because they may change, like it may be discontinued if the CT count is more than 100 for 3 to 6 months or longer because of the potent combination. ART, reinitiate secondary prophylaxis if the CD4 counts decrease to the less than 100. We used as a secondary prophylaxis where I was working with the ganciclovir with the patient with the transplant, because it's very common in post-transplant patient, the CMV. It's very, very common, and those who are working in the transplant center, they are very well aware of it also. So primary prophylaxis not recommended in the patient with the CT count less than 50, but regular fundoscopic examination are recommended, because colitis and esophagitis is very common in the immunocompromised patient, and they have CMV. Toxoplasmosis. I just have I just saw one patient throughout my clinical practice with the toxoplasmosis, and it's basically the main reason to be infected with like the uncooked food. So like it's very common. So the patient's symptoms are basically fever, headache, altered mental status, and the focal neurological deficit is usually very common. Patient has emphyresis, aphasis, ataxia, visual field losses, nerve plesias, and the seizures is also very common in these kind of a patient. And we can also see that the CSF, the mild pleocytosis, increased proteins is if it's present, so it's mean that the patient has the toxoplasmosis gondii. And but in my experience, what we came to know about the patient diagnosis is after the patient scanning that there was a bilateral hypotensive lesions. So it's very important to get the scanning, and then for the reconfirmation that which kind of infection is that. The antibodies or T condyle isolation on the serum or the CFS test has been recommended, and sometimes the brain biopsy also do for the worst kind of infections. So treatment of the toxoplasmosis, preferred regimens, pyrimethamine with the sulfadizine. It's very common, and we also use these because these also causes a bone. Just a moment. bone marrow suppression, thrombocytopenia, granulocytopenia, anemia, and these are very common. So that's why folinic acid has been used for these patients to eliminate or to reduce bone marrow side effects of the pyrimethamine. And the duration is 6 days or after the sign and symptom resolve. As an alternative therapy, clindamycin, trimethoprim with sulfamethoxazole, atovaquone plus the sulfadiazine, atovaquone single with the pyrimethamine. So these are the different regimens, alternative regimens also being used for the toxoplasmosis. Prophylaxis may also recommended primary if the CT count is less than 100, trimethoprim with the sulfamethoxazole double strand once daily, or sometimes dapsone, pyrimethamine, leucovorin with the leucovorin or atovaquone is also recommended. In the secondary prophylaxis, pyrimethamine and the clindamycin are most commonly used with the drugs, and there's also the alternative drugs or can also be used like trimethoprim, sulfamethoxazole, atovaquone plus the pyrimethamine, atovaquone with the sulfadiazine and atovaquone. So there is another one question. There is a that is a 42 years old HIV positive man with a diagnosis of CMV rhinitis 9 months ago. Since then, he has been treated with the valganciclovir. When he received the diagnosis of the CMV rhinitis, the CD4 count was 17 cells, like less than 100 or 50 that we already discussed for long. And he was initiated on the combination ART 3 months ago. The CD count was 175 cells. So today his CD count is 312, which is the best recommendation for the valganciclovir therapy in JZ conditions. I think you guys don't have. Yeah, answer is A, like the discontinue valganciclovir because his CD counts has been above 100. Like you can't confuse with the first they gave 17 and then they said that today is 312. So when you are answering the questions, you just be concentrate what they are asking. Just don't be rushed and mark the wrong answer. TB. TB is Mycobacterium tuberculosis. You guys mostly, I think, people aware of it. Somebody answered the B. I already answered. It's not B. Okay, so usually we know that the Montauk talks with those who are in the clinical setting, they know that it Montauk talks, the tuberculin test, like intradermal interaction, it has been used and for the diagnosis of the tuberculosis. I'm not giving you a lot of detail about it, like there may be chance for the false test. Negative tests occur in 15 to 20% of the people infected with. So the Mycobacterium tuberculosis primarily in those recently infected or allergic. So like IgRA, that interferon gamma release assays is commonly used for the confirmation of the TB. So yeah, it should be done, and the booster effects. So non-specific signs and symptoms, if we think of tuberculosis like cough, malaise, weight loss, fever, chills, night sweats, and thoracic pain is very common. Radiologically, we do the chest X-ray or radiography patches. We can see the patches or the nodular infiltrate in the upper lobe of the lungs. So you can able to identify that as maybe something TB. And microbiological testing like required sputum smear for AFB. AFB means acid fat bacillus testing, and sputum culture for Mycobacterium tuberculosis. And IgRA is very commonly used in the Western world for the confirmation of TB. And it also given test is also very important for giving the prophylaxis also. Testing for the latent tuberculosis, but so like it's also important, like for the if the patient is they don't have a active infection, but they may be the latent tuberculosis. But I already told that the IGRA recommended if the history of the BCG vaccine or likely to return to have TST red. So that's why this is testing is very important. And if there is low to high risk, there is a criteria like positive skin testing, and then when we have to conduct these kind of a test. So just go through it and check it very. It's because this is also implemented in our practices also. So not related with the HIV, you may also able to with the normal people. But I think in the Pakistan, I don't know, IGRA is not everybody is, having these facilities. Recommendation treatment for the latent TB, HIV infected person, close contact of the people with the diagnosed infectious TB. So if somebody is around with this, so they have to take the prophylaxis. The people with the abnormal chest radio, graphic that show the fibrotic lesion likely to represent old or healed TB. So maybe also get the treatment. Immunocompromised patient, organ, I already told you, the organ transplant recipient taking the equivalent of more than 15 mg per day of the prednisolone for more than 1 month, because all the patient with the organ transplant take the high doses of the corticosteroids, especially prednisolone. So they should be taking treatment for the latent TB. For the prophylaxis, receiving tumor necrotic factors alpha antagonists, they may also take that. And the foreign-born people from the high prevalence country, because I already told you that it's test related with the this is American test, but that's why they mentioned that the foreign-born people, like we have a more prevalence of the TB in our country. So that's why the immigration within the 5 years, they must also take the latent TB prophylaxis. Injection drug users, people working at or the living at the high risk setting, nursing homes, homeless shelters, hospice cares, and whatever. So they also have to take if they treatment for the latent TB. And microbacteriology laboratory person, they all have to take that one. The children under the 4 years of the age of the children and the adults and exposed to the adults in high risk categories may also take that. So dosing. These are the different dosing, because we have short of time. I'm not going to give you the lots of information about the dosing. So different drugs have been used: isoniazid, rifampicin, rifampicin, rifampicin with plus isoniazid. This combination is very commonly used, but is unfortunately not recommended by the CDC, but is used in the Western world a lot. Patients who are co-infected with the HIV administered isoniazid. For 9-minute alternative, isoniazid is also used. Areas with the multi-drug resistant isolates, 2 drugs with the activity against the isolates for the 6 months, 6 to 12 months may also use. So these are the patients. This is a chart which is very important related with the therapy, like intensive phase, which drug has to be given for how long, and patient without HIV and patient with HIV. So it's very important. So just go through it and related with the different regimens, ARTs, like if the patient is taking PIs and NNRTIs, so which drug should not be co-administered with the rifampicin. So just go through it. Recommendation treatment for the active TB, principle of the treatment, like what is the principle, why we have to treat. The regimen, the organism are susceptible, and the drug therapy must continue for the sufficient period. Therapeutic option for the treating active TB. It's very important. First line agents are usually these 4 drugs: isoniazid, rifampicin, pyrazinamide, and ethambutol. So you can also recall as like IRPE. So this is the first line. And the second line, there is amikacin, bedaquiline, and capromycin, cycloserine, and ethanamide. And there's lots of drugs available, but most of them, it's unfortunately not available in the Pakistan, but you have to go through all of these drugs and their doses protocol if the second line therapy is used when the first line is not working. So active TB treatment, like what are the, I already told you what are the recommended, like in the intensive phase, which drug has to be given patient with the HIV and without HIV, and what are the optional, drug regimens have to be given. So just go through this chart is very good and very interesting to recall and remember. And rifampicin can be substituted for the rifampicin in the patient taking the NRT with the rifampicin, but the rifampicin doses may need to be increases to the 450 to 600 mg, because you can go through their pharmacokinetics, their because they are, substrates for the CYP enzyme. So just taken into consideration. Patient may take PIs with the rifabutin, but the rifabutin doses should be decreased to the one. So that's all related with the metabolism. So you should go through it. So how, if the patient, maybe they will ask that the patient is taking rifabutin, how the doses of the PIs or like antiretroviral therapies should be given for that patient. So just go through all of these things. And yeah, the known isoniazid, INH isoniazid resistance is very common in the different part of the world. So the administration or the rifampicin, paracetamide, ethambutol, and the moxifloxacin is also used, or with the levofloxacin. And continuous phase should be completed with the rifampicin or rifabutin plus ethambutol with moxifloxacin or any fluoropyrimidines, which is recommended for 7 months. And known rifampicin resistance is also it's also in our country also. So you have to we know that the MDR-DB or HDR-DB. So these are the different regimens that has been given. So administer INH, paracetamide, and ethambutol and streptomycin. So there is another question RV is a 35 years old man who presented to the emergency department with a persistent cough, night sweats, and unintentionally 15 kg recent weight loss. He has been homeless for over 3 years and has been living in multiple shelters in the city. An interferon gamma release assay that I already told you, IGRA, the test is positive and his sputum is AFB is also positive. He is not HIV infected. Which of the following would be the best empirical therapy for him? So these, what are the initial drugs, that's the 4 drugs, and for how long it has to be taken, so that give the answer accordingly. Now to the antifungal therapies, like amphotericin B is clinically used, is very in the different kind of infection, definitely the fungal infection, very commonly with the cryptococcal meningitis or systematic fungal infection. So amphotericin B is used because it's already available in the parenteral form. So, and the adverse effect is very common, like renal toxicity. We see lots of patients with the renal impairment when they are having on the amphotericin. Thrombophlebitis is very common in these patients. So when you are giving that, there has to be given the, some preventive measures for these patients. Sometimes they said that should be given through the central lines, but we literally seen a very few times this, and the fever percentages are very common when they started with the amphotericin. So pre-match is also recommended for these patients with the hydrocortisone and ibuprofen or paracetamol, whatever. And sometimes patient has their triggers, so treatment with the meperidine is recommended. So as a antifungal like ketoconazole, it's very commonly used in different settings. So clinically is also in the histoplasmosis, superficial candidiasis infections. So and it's basically adverse effect is adrenal insufficiency and decreased lipoid. That's why it's also used in the lots of as a treatment option in the patient with the prostate cancer because of the side effects. And the gynecomastia, menstruation regulation, and elevated liver function is common with these drugs. And all the antifungal, they have a very strongly substrate of the CYP3A4 inhibitor. So please check when the patients are on the antifungal and if they are taking co-administration with other drugs. So there has to be very in concentration. Fluconazole is also used in the Candida infection and the cryptococcal meningitis. And it's also the inhibitor, and more than 400 mg per day, and the CYP inhibitor at the lower doses is required. And itraconazole is basically used for onychomycosis, histoplasmosis, spiritulosis, plastomycosis. So these are also very commonly infections with the patient, immunocompromised patient, and it may cause the elevated liver function and the potential fulminant of the hepatitis. So that's why, or also precautionally given with the patient with any heart disease or heart failures. So itraconazole should not be given with the patient with heart diseases. And voriconazole is also available in the Pakistan, and those who are using it, they're very well known aware of it. Resistant Candida infection, definitely if the patient is not treated with the fluconazole, the voriconazole is a very good drug of choice, and the aspergillosis, histoplasmosis. And Yeah, it has also so many side effects like abnormal vision and very badly liver functional. It's really because we see that the patient with the voriconazole and the posaconazole, it has affected liver functions a lot. So the patient with already underlying liver diseases, we have to be very careful, and the patient have a resistant fluconazole, resistant to fluconazole, and you have to give the voriconazole or the fluconazole. So it should be keep in mind that how to check that liver function test and things to be considered very closely. For the patient who are receiving phenytoin, increased dosage of the voriconazole, we know that the phenytoin is also the inducer. So increased doses of the voriconazole may also use. Doses reduction for the moderate or the severe cirrhosis may also be recommended. There are the different drugs and their effect and their recommendations related with the different, antifungal. So this chart is very good when you are dealing with when you are preparing for exams, like which drugs are contraindicated. If ampicillin and voriconazole, they are contraindicated, definitely it should not be given. And same like the patient is having the cyclosporin, that what you have to do, like the reduce the dose half in. And if the patient is taking tacrolimus, so what is the effect with the tacrolimus? It increases the tacrolimus levels, so definitely reduce the tacrolimus doses, because they may have a much more toxicity because of the more tacrolimus available in the blood. So yeah, you have to be check all of these, and it's very especially with the PPIs, these they have a very bad interaction. So we have to check with the dose of the patient PPI doses and the voriconazole doses. And yeah, very importantly with the anticoagulant like warfarin, you have to be very closely monitored PTINR, and it's just the warfarin doses as required. So posaconazole, I already discussed about what's the thing about the posaconazole clinical use as the Candida infection, aspergillosis, zychomycosis, and fusariasis. And the adverse effects is increased LFTs. I already told you that very, very badly, and hypokalemia. And thrombocytopenia and QT prolongations also may use better. I'm very aware of the adverse effect related with the liver and the hypokalemias. It's also inhibitor, so just decrease the absorption of the PPIs and H2. So that's why the drug, dose alteration or, dose checking is very important. So I saw viconazonium is also the product, and it's very common. It's very good drug for the aspergillosis, and especially with the mucormycosis. But unfortunately, I never seen this drug. And according to the research, it has a very good in the mucormycosis, and with the patient with the immunocompromised patient, mucormycosis and aspergillosis is very, very common too. And it's all the, all the antifungal, they have very badly affected the liver function test. So you should consider that in the hypokalemia. So yeah, just check that. And it's also caused the peripheral edemas, back pain. And you can also check with the P-glycoprotein mal inhibitors also, like PG. If anybody go through with the dose adjustments, so you can see that if which kind of the metabolism and substrates they inhibit or induce. So how to check the doses and alter the doses or modify the doses. Echinocardins like casmofungin is usually used for the invasive candidiasis, or you can say the candidemias or fungemias. So yeah, the casmofungin is also used as only available in the IV infusion and has a side-related reactions, drug interactions. And casmofungin are also used with the cyclosporin or the tacrolimus, and this was very challenging for us to use the casmofungin with our transplanted patient. So yeah, but sometimes you have to go through it and check this because of you have to save the patient life. So mycofungin and avoid the contaminated use with sirolimus or nifedipine, and endocrine, there is no interactions. So thank you so much. These are the different referencing that has been used, like ACCP 2020 and 21 pharmacotherapy. I don't go through a lot of things from the 2020 and 2021, but I just go through it randomly. I check a lot of not a lot of, but I didn't see lots of difference in both of them. But if you have a copy of them, you can check it deeply and the CTC guidelines and IDSA and just go through for your exams and check with all the updated information before your exam, because your exam is more related with evidence-based practices rather than just the theories. So thank you so much for listening me, and thank you to the Giving Back to the Pharmacy in Pakistan for giving me the opportunity once again to talk to all of you. Thank you.
Thank you very much, Dr. Sidra.
Yes.
Participants, if you have any question, you may ask right now.
Or you can just ask on the ID group or with the, I think with the, you have another group for these students, if I'm not wrong.
Yeah, exactly. We have another group. If anyone is specializing in infectious disease, we can add them in their group.
Yeah, so if there's any question, if you're related with that, so just feel free to ask any question. And yeah, I'm not good in the HIV, I know that, but rest of them, because I didn't see lots of patients with HIV, so I may not be the very good person to answer you, but the other, expertise, especially the Rehan from Chapatin, he's dealing with a lot of HIV patients, so we may, give you very good information related with that. So,
Ji, bilkul. Thank you very much again, Dr. Sidra, and all the participants and Giving Back to Pharmacy in Pakistan and all the members. Dr. Sidra ने हमारे लिए आज टाइम निकाला है और मैं समझ सकता हूँ कि उनकी तबीयत बहुत ख़राब थी और बड़ी मुश्किल से उन्होंने प्रेजेंटेशन कंप्लीट की है. Thanks again, Dr. Sidra.
Like, I really want to give some more information, but I'm really sorry. But
no, we can completely understand this. No doubt, we have to understand, and really you were very sick. Hope get well soon as well. And for the participant, we have our next lecture on the coming Tuesday. So hope to see you soon, all of you again, inshallah. Assalamu alaikum.
Thank you very much, everyone.
Dr. Sidra, if I have any personal query, I will get back to you.
Oh, you're more than welcome. Okay.
Thank you. Thank you.